This week I'll be covering Rh factor alloimmunization. So our blood typing system, the ABO system, has either Rh positive or Rh negative antigens which are attached to the red blood cell. And this Rh blood group system consists of over 300 antigens. The more common are D, C, CE, and E. In this presentation, we'll mainly be covering D, but a lot of the management is universally the same for other positive antigens. So by day 38 of gestation, the D antigen is expressed as a part of the red blood cell membrane. Once the anti-D immunoglobulin IgG antibodies are pregnant in an individual's circulation, it can cross the placenta and mix with fetal red blood cells, resulting in fetal anemia. D-negative moms who are exposed to D-positive red blood cells are at risk for developing anti-D antibodies. And this exposure would include transfusions, like blood transfusions, fetal maternal bleeding, such as miscarriage, pregnancy termination, ectopic pregnancy, antepartum vaginal bleeding from placental previa or placental abruption, abdominal trauma or delivery, as well as shared needles. Widespread use of the anti-D immunoglobulin during pregnancy and postpartum, this is more commonly known as ROGAM, has dramatically reduced but not eliminated all D alloimmunizations caused by the fetal red blood cells that have gained access to the maternal circulation. Now, some risk factors, starting with pregnancy risk factors, would be the Rh blood types. So when the mother and fetus have a different Rh blood types, alloimmunization is more likely to occur. ABO incompatibility, when the mother's red blood cell lacks an A or B antigen, but the fetus's blood cells have the antigen. Blood transfusions, a blood transfusion during pregnancy is actually the most common risk factor for alloimmunization. And then other procedures such as amniocentesis or abdominal trauma can cause alloimmunization. Other factors would include age. Generally, older patients have higher risk. Other diagnoses such as like sickle cell disease or autoimmune conditions. Exposure to the antigen, and then variabilities in the blood collection can also cause some risk factors for this, as well as exposure to past blood group antigens. Maternal consequences, immunologic response, antibody production. The immune system produces an anti-D antibody against the Rh positive red blood cell. These antibodies can cross the placenta and attack red blood cells of the fetus in subsequent pregnancies. So this would increase the risk for needing intensive monitoring in subsequent pregnancies, pregnancy complications such as miscarriage or preterm birth, and then a lot of psychological impact with emotion and stress. The fetal and neonatal consequences, hemolytic disease of the fetus, which is associated with serious morbidity and mortality. It's caused by the destruction of red blood cells of the neonate or fetus by maternal immunoglobulin G antibodies. And then the different subsets of this is RHD hemolytic disease, ABO hemolytic, and then other, meaning that this refers to the other 300 antigens. Hydrops fetalis would be two or more of the following: skin edema, ascites, pericardial effusion, or pleural effusion, and occurs when the fetal hemoglobin deficit is at least 7 grams per deciliter below the mean of gestational age, and then thrombocytopenia and neutropenia. This increases the risk of severe anemia. It is more common with the hydropic fetalis. Some subjective data, if the patient reports that they have a known history of alloimmunization, if there is IV drug use, or there's unknown paternity. And some objective data to keep in mind is what is their ABO type screen, what is an antibody screen, what are their titer testings, and then recorded history of alloimmunization. For a presenting mom, you likely won't see any physical signs. It's a lot of lab testing. More so, you're going to see this with your diagnostic testing of the fetus and then of the neonate, which I'll certainly be going over. Listed here are some differential diagnoses. And then getting into how we diagnose alloimmunization. Now there's a lot of different testing out there. I'm going to kind of cover each one of them and just talk about which is the more common that we would see being used. So the diagnosis of alloimmunization is based upon the detection of anti-D antibodies in maternal blood. There is a risk of false positive screenings for anti-D antibodies. And it may not be helpful in de-alloimmunization if the patient has received RhoGAM within the past few weeks. Now, starting with prenatal RHD typing, this essentially is having the father be tested. It can be used as an initial step in antepartum management to determine what the fetal RHD type is. D-negative fetuses is not at risk for complications from a maternal anti-D antibody, since the red blood cell does not carry the target antigen. So if the biological father is negative, then the fetus must also be negative. But if the biological father is positive, it's helpful to know whether it's a homogeneous or heterogeneous for RHD. As a homogeneous, all of his offsprings would be positive, versus the heterogeneous, or maybe it's not available testing, whether it is an unknown paternity, things like that. You would want to do further evaluation with free cell DNA testing of the maternal plasma. And then this chart is just from Up to Date. I'm more of a visual learner, so this was really helpful for me. And it just goes over, if the testing is negative, what's the next steps? If it's not available or uncertain, what would you do? And then if it's positive, where would you go from that? So it's just an easy chart to follow. Now, free cell DNA testing, it's a test of maternal plasma after 10 weeks gestation. This is actually more commonly used in the UK and Europe, but it is available for use in the US. False negatives can occur if it's completed too early, so if it's done prior to that 10 weeks gestation, or if the lab technique is not appropriate. And now a positive result would be if there is presence of the RHD exons in maternal blood. Then that indicates fetal cfDNA is present and the fetus carries the RHD and then is D positive. And if there is absence of it, then the fetus does not carry the RHD and is thus D negative. Next is what we do commonly use here in the US with an amniocentesis. So a fetal RHD status can be determined by PCR on an amniocentesis after 15 weeks gestation. If a fetus is D positive, then they need to be monitored for the hemolytic disease of fetus with serial maternal lab titers, which generally is the indirect Coombs titer. And when a titer is reached, then you would want to complete Doppler evaluation of the fetus by middle cerebral artery peak systolic velocity. Abbreviation would be MCA-PSV. Some mothers with a de-alloimmunization develop antibodies to more than one blood cell antigen, especially other antigens including C, and E. There are no specific guidelines in managing these pregnancies. It's more so similar following to the anti-D antigen that's present. But it just would want to just be aware that they can carry more than one. And then the D-negative fetus, then they're not at risk and there doesn't need to be continued monitoring. Now the indirect Coombs, and I did put here the GMA as well. It's not, the GMA is not routinely used. I just left it here because it was listed in a couple of different resources that I reviewed. More commonly used is the indirect Coombs, which looks at the anti-D antibody present that will adhere to the red blood cells. Essentially, how the testing is done is they wash and suspend the sample in anti-human globulin, which is the Coombs serum. And a positive test is when the red blood cell coated with maternal anti-D will be agglutinated by the anti-human globulin. And then the titers, basically when you're reading it, it dilutes like 1 to 16, means that the plasma is positive at any dilution down to 1 part plasma to 15 parts dilution. Anti-D titer of 16 is considered a critical value. Now, so when your indirect Coombs test does reach that critical value, the next step would be the MCA-PSV, and this evaluates the severity of the anemia, so that's when that's reached there. And essentially what this test looks at is the fetal hemoglobin levels determined by the blood flow to the MCA. And this increases as the fetal hemoglobin level falls. And so usually serial testing is done every 1 to 2 weeks. Now for a volume of less than 1.5, you would want to have the antenatal testing at 32 weeks gestation. And if no transfusion is performed to the fetus at this point, and it remains less than or equal to 1.5, then generally a delivery is scheduled at 37 and 0 days to 38 and 6 days gestation. Now, if the result is greater than 1.5, then there will be a intravascular fetal transfusion, which generally is limited between pregnancies of 18 and 35 weeks gestation. For fetuses that don't undergo transfusion, then you would want to proceed with delivery of the newborn if it's greater than 35 plus 0 weeks of gestation. And then if fetuses were transfused, you would still want to typically consider delivery at 37 plus 0 weeks to 38 plus 0 weeks of gestation, whether a cesarean birth is scheduled. And then again, here's a nice chart of just what you would do for follow-up and when you should perform the MAC-PSV testing. Now, treatment. The first pregnancy with an alloimmunization complication is typically managed differently from subsequent affected pregnancies, as the anti-D titer is usually lower at the beginning of the first affected pregnancy and severe anemia might not develop. But in subsequent pregnancies, fetal anemia is more severe and develops in earlier gestation. So you'd want to do close monitoring with MCA-PSV and serial titers and consider transfusions. Now, the general approach when you are looking at the fetus is or may be D antigen positive. You would want to screen all moms at their first prenatal visit. And then if it's positive, D negative patients who screen positive for anti-D antibodies should not receive RhoGAM. Now, antibody screening negative, candidates for anti-D immunoglobulin at 28 weeks. So this is a mom that's say like O negative. You would want to give them RhoGAM at 28 weeks or after delivery of a D positive newborn after an antepartum event associated with risk of fetal-maternal bleeding. And that would be a single dose of RhoGAM at 28 weeks, which is 300 micrograms IM. And then selected for prophylaxis if there's a pregnancy complication that's associated with fetal-maternal bleeding, such as pregnancy loss or termination, whether that is, first trimester, second trimester, anything less than 20 weeks, invasive prenatal testing, therapeutic procedures, blunt trauma to the abdomen, ectopic pregnancy, threatened abortion, fetal death in the second or third trimester, bleeding in the second or third trimester, you would want to give that RhoGAM as well, which would be the 300 micrograms IM. And then postpartum, RhoGAM should be given to all non-alloimmunized D-negative patients within 72 hours of delivery of a D-positive newborn. And again, that dose would be 300 micrograms IM. Postpartum testing for all D-negative patients, especially if there is excessive fetal maternal bleeding after delivery, you would want to do a Rosette test, which is a qualitative test as an initial screen. And if it's negative, no further action. If positive, then you would want to do the Killer-Beck test or flow cytometry to determine the percentage of fetal red blood cells in the maternal blood. Now, you would want to multiply this result by 50 to estimate the volume of the fetal maternal bleeding for the amount of the anti-D immunoglobulin needed. Also, postnatal evaluation. This is evaluating the neonate. You would want to evaluate for RDN if the mom's antibody is positive or unknown, or showing clinical signs, jaundice within 24 hours or symptomatic anemia. In these patients, you would want to refer them to fetal maternal medicine specialists, who are proficient in performing invasive diagnostic procedures and therapeutic procedures, and also would consider a referral to reproductive medicine as well if they are planning to have pregnancy in the future. Now, education on this, you'd want to educate what causes alloimmunization, prevention and treatment, including monitoring and testing, how it happened, is there an exposure and antibody function, prevention, monitoring, including the blood testing, ultrasound, intrauterine transfusion, complications without prevention, which would include the NDH, miscarriage, stillbirths, and counseling. And some action steps for the patient is to know their RH status, adhering to their treatment, attending appointments, report any bleeding or trauma, and be careful with planning pregnancies. And like I just mentioned, in prevention for future pregnancies, consider IVF with pre-implantation genetic testing, use of a genetic carrier, or use of donor sperm. And then here's my references.